Hey everybody, welcome to our first post for National Infertility Awareness Week. Today, I thought we'd start off with one of the most important topics that we address almost on a daily basis, which is advanced maternal age, and what that means and what do we generally recommend for patients in those situations. So basically, let's define it first. Advanced maternal age technically is after the age of 35. From a reproductive standpoint, we usually use the threshold of 37 as our cutoff, in the sense that is where we see a steep drop in pregnancy rates and a sharp increase in miscarriage rates. That happens to coincide with a pronounced increase in abnormal eggs, if you will. It's called aneuploidy. And what that means is that in general terms, and just dumbing it down for just a second, it means that the DNA within the egg is a little bit rusty. It's been there for a longer time. Women are not making eggs on a daily basis like men are making sperm or maturing sperm on a daily basis. So the process becomes a little bit more difficult with the passage of time. The test that we normally use to identify this, other than just knowing the patient's age and their birth date, is basically two of them. There's one that are called cycle day 3 labs, which are FSH, LH, and estradiol. The most important ones are FSH and estradiol. FSH being a hormone that the brain produces, which is sent by the pituitary down to the ovary. And normal values are generally less than 10 and ideally between 5 and 8. The estradiol level has to be measured at the same time, and the normal values are less than 65 and ideally less than 45. So these are really, really important because they're different metrics that help us to identify objectively, or as objectively as we can, what the reproductive prognosis is. The other thing that's really important is the ultrasound that we do here in our office, and most women get done on a pretty regular basis with their OBGYNs. What's important about the ultrasound is that what we need to measure is the volume of the ovary and the antral follicle count. It's very important, and again, just to use it anecdotally, or as an example, the ovary is like an egg. The ovary is like a balloon full of marbles. The marbles, let's say, are the eggs, and as you lose more marbles or more eggs, the ovary starts to contract and makes it smaller, and we can usually get a pretty good assessment of where a woman stands as well, and along with those other blood tests with the ultrasound, which is extremely, extremely important. So in general cases, the way that we address advanced maternal age is to try to take a more proactive stance than just saying keep trying for the most part. But as far as what my position is on it, is that we always have a dialogue with patients and we come up with a game plan that works for everybody. Not everybody is completely gung-ho and wants to go to the most extreme treatment options. Some people are more in tune with going down the more conservative route and working their way through the spectrum of things, and that's completely acceptable. It just depends on where they stand and how normal or abnormal all of these tests that we do are, and of course the most important predictor is age. When we talk about risks for the baby and what advanced maternal age is really more because the aneuploidy rate becomes higher, and with that, an egg is less capable of being fertilized, and if it gets fertilized, it's less capable of implanting, and if it implants, it's less capable of developing on, and usually will result in a miscarriage. Most chromosomal abnormalities, which at the end of the day is what we're talking about, or aneuploidy, are not compatible with life, and that's why most of them result in a miscarriage. And it's very few people, for example, that will have a pregnancy that goes to term when there is a chromosomal abnormality. The most common one is Down syndrome, and a little known fact is that even though Down syndrome babies occur more often in women that are older, the same number of children with Down syndrome are born to women less than the age of 35 as they are above the age of 35. Again, because most chromosomal aberrations are not compatible with life. The other things that we have to consider is how old is the patient, because from a maternal standpoint, pregnancy is not easy on the body, whether you're 20 or you're 45, and we've got to take very significant precautions to mitigate complications or problems from happening during or after the pregnancy or during the delivery portion. Obviously, we want to make sure that a woman's weight is well taken care of, because that can predispose to hypertension and diabetes, as well as multiple other complications, including at the time of delivery, more likelihood for C-section, more complications with the C-section, including bleeding, infection, etc. So those are all the things that we look at. We want to look at a patient from a holistic standpoint and not just say, let them get pregnant and do whatever it takes to get pregnant. We need to look at the whole person and everything that includes, and look at the whole couple for purposes of this conversation. This is a team sport essentially, and the man is just equally important. And advanced maternal age is also something that we have now known to be a very important factor playing a role in pregnancy in general. In terms of men, we generally use 45 as the cutoff for advanced maternal age. And the reason for that is that we have noticed that there is an increase in fragmentation within the sperm. What that means is that the sperm, just like the DNA in the egg becomes, let's say, rusty, well, so does the DNA in the sperm, and it tends to break off, and we see a higher association with cognitive delays, autism in children that are associated or been born from a father who is above the age of 45. And so we want to take very good precautions that if we're helping somebody to achieve a pregnancy and we're manipulating sperm, then we try to choose the best sperm. And so we do some tests to help us identify good sperm from bad sperm or other abnormalities. Finally, in terms of treatment options, like I said, timed intercourse is always an option. But in terms of what we can offer patients, generally there's two main things, possibly a third that we can add in there, which is either ovulation induction and artificial insemination or IVF. And in vitro fertilization is on one extreme, and IUI or timed intercourse is on the other extreme. The only reason that one is more successful than the other is just because these treatment options, they allow us to control for as many variables as possible, more so than what can happen in the privacy of a couple's home. And so, like anything in life, the more options, or the more variables that you control for, the more likely you are to achieve the goal that you want. So this is our first post for National Infertility Awareness Week. I hope you were all interested, and I look forward to hearing any questions or concerns or any insights on anything that I've said today. Bye. I'll see you tomorrow.